The transfer of a critically ill patient to the ICU from either the ED, the OR, or the medicine floor is a crucial part of any hospitalization. Given the patient's critical status, it is imperative that all team members, both transferring and receiving, are on the exact same page. This highlights the importance of having a very diligent and standardized transfer of care process. Historically, this transfer of care and handoff has been done on a more individualized or private basis, with the receiving RN in the ICU getting handoff from the transferring RN, and the receiving RT in the ICU receiving handoff from the transferring RT or a CRNA if the patient's coming from the OR. Here at Our Lady of the Lake, we aim to transition from this separate, individualized process to a more patient-centered approach, placing all of these team members simultaneously at the patient's bedside so that all patient support systems can be both accounted for and verified to be functioning properly. Let's take a look at how this process should play out. When a patient is critically ill, the house manager will receive a request for an ICU admission or transfer. They'll subsequently place that patient in an ICU room and the transfer process is initiated. If the patient is coming from the ED to the ICU, the ED RN as well as the ED respiratory therapist will accompany them to the ICU. If the patient's coming from the OR, the CRNA on duty as well as the operating room RN will accompany the patient to the intensive care unit. While the patient is being transferred, the ICU RN as well as ICU respiratory therapists will prepare the room for their arrival. This includes readying any IV pumps, drips, and a ventilator if necessary. The patient arrives at the ICU and there is a collaborative effort to transfer the patient to the ICU bed. The ICU respiratory therapist works to transition the patient from the transport vent to the in-room ventilator. Meanwhile, the ICU RN will work to transition the patient from the transport pump to the in-room IV pump. The ICU respiratory therapist checks the ventilator to ensure that it is active and has the appropriate settings. The ICU RN then begins their assessment of the patient. This includes 2ID verification, checking along with the transferring nurse for any pressure-related injuries, and then finally verification of any active drips the patient's currently on.
This is Mr. Smith. He's a 60-year-old male. He came into the ER complaining of abdominal pain. It was discovered that he has a perforated bowel. Dr. Jones performed an emergent exploratory laparotomy and a bowel resection. In the OR, we gave him 4 liters of crystalloids and 1 liter of albumin 5%. His EBL was 200. And we had to administer multiple doses of neosynephrine. So we switched him over to a levo-fed infusion. Patient received rocuronium and succinylcholine for his paralytics, and we reversed that with Shigamidex prior to leaving the OR at the end of the case. Patient is running propofol and getting PRN doses of fentanyl for his sedation. I have put in ventilator orders and ventilator bundle. I put in orders for his sedation and his pressors. He has a goal of RAS of -5. With the propofol infusion, it's running at 40 mics per kilo per minute. With the PRN doses of fentanyl, cardiac-wise, he has been running sinus tachycardic, 105 to 115. We've been sustaining his blood pressure with the levo-fed infusion. It's running at 0.1 mics per kilo per minute. He has a goal to keep his MAP above 65. Respiratory-wise, he is intubated with a size 8 ET tube. It is measured at 22 at the teeth. His vent settings are 400 tidal volume. He's on assist control, 400 tidal volume. His rate is 16. His FiO2 is 40%, and his PEEP is 6. His breath sounds are coursed bilaterally, and he does have equal and symmetrical chest expansion. In the OR, we also placed a triple lumen right IJ central line, which all his sedation and pressors are running through. The dressing is clean, dry, and intact. We also inserted a right radial A line. Dressing is also clean, dry, and intact. We inserted a OG tube. Right now the OG tube is clamped and it is measuring 55 centimeters at the teeth. We also inserted a Foley for hemodynamic monitoring and urine output, and his urine output was 30 mLs for the whole case. Other than that, we didn't have any issues with Mr. Smith. His wife is waiting in the waiting room, and we have already spoken to her, and she's aware with how the procedure went and how everything went.
Okay, Sharonda, I have this patient from the ER. He is currently on assist control of 18, 350, 40%, 5 at the peak, 7.5 at the teeth, and 23 at the gum. And he's done very well. Are you ready to switch? Okay. Their sounds are good and symmetrical.
All right, hey Carmen, it's Christy from the ER. I have Mr. Smith here. He is a 56-year-old male. Family hadn't heard from him in a couple of days, so they went to check on him. He was found down on the ground, ultravital status. They called EMS. He was hypotensive, tachycardic with EMS. Only waking up to painful stimuli. Brought him into the ER. Remained hypotensive and tachycardic after a 500 cc bolus by EMS. So we went ahead and decided to intubate. At 3 o'clock, he was intubated with an AO-ET2, 24 at the teeth. We gave him 100 of Sux and 100 of ketamine. We followed up with propofol drip at 30 mics, and that's been keeping him sedated. We did all the basic labs, blood cultures, lactic acid. Lactic was elevated at 8.1. We went ahead and gave him a gram of zinc, 2 grams of sapropine. We do have a peripheral line that we started here, a 20 gauge in his left AC, but he remained hypotensive after the sepsis fluid bolus, so we went ahead, started a central line and hung 11-fed and vasopressin. His review of systems is his lung sounds are coarse in the right lower lobe. His skin was hot to touch. We found he had 102 rectal temp, so we gave him a gram suppository of Tylenol. We put a Foley in him also. Abdomen soft. Pulses were 1+ radial and pedal. Family did show up. Medical history is hypertension, diabetes, and allergic to penicillin. And family's in the waiting room.
After verbal handoff is completed, the ICU RN scans the QR code on the wall and completes the associated questionnaire. The ICU RN will document their name, the patient's MRN, whether the patient is actively on a ventilator, whether the information transfer was completed appropriately, and whether the technology transfer was completed successfully.